You've heard of a heart attack, right? Well, what if I told you there's something called a brain attack? It's an attack that happens inside your head, where every single second, literally every second counts. Today, we are going to break down acute ischemic stroke, a true medical emergency where time is everything. So let's get right into it.
Here's what we'll cover. We're going to follow the entire journey. First, we'll get a handle on what a stroke actually is. Then, we'll dive into the emergency room and see the race against the clock during diagnosis. After that, we'll look at the amazing treatments that restore blood flow. And finally, we'll talk about the aftermath, managing complications and, most importantly, preventing another one.
All right, so let's start with the absolute basics. What exactly is an ischemic stroke? What is going on inside the brain when someone has this so-called brain attack?
Okay, so an ischemic stroke is, at its core, brain tissue that's starting to die simply because its blood supply got cut off. I want you to think of it like a major plumbing blockage in a critical pipeline that feeds your brain. And unlike just a temporary clog, this one is serious. We know it's a full-blown stroke if the symptoms last more than 24 hours, or if we can actually see the permanent damage on a brain scan.
Now, you've probably heard of a TIA, or a mini-stroke. So what's the difference? Well, a TIA is a temporary blockage. The symptoms go away and there's no permanent damage left behind. But, and you have to hear this, a TIA is a massive, flashing red warning sign that a full-blown stroke could be right around the corner. You just can't afford to ignore it.
So what's causing these blockages in the first place? Well, it usually comes down to one of three main culprits. First, you've got atherosclerosis. That's when plaque builds up in the large arteries, kind of like rust building up in an old pipe. Second is cardioembolism. This is where a clot actually forms in the heart, often because of a condition like atrial fibrillation, and then it travels up to the brain. And the third cause is small vessel disease, which, just as it sounds, affects those tiny, deep arteries.
The thing about stroke symptoms is that they happen suddenly, and they tell you exactly which part of the brain is being starved of blood. You might see someone having trouble speaking. That's aphasia. Or they could have weakness all down one side, which we call hemiparesis. Sometimes it's a total loss of sensation or numbness on one side, hemianesthesia. You can even have these bizarre visual problems, like someone suddenly can't see anything on their left or right side. That's why the FAST acronym, face, arms, speech, time, is so important for everyone to know.
Okay, quick review of Part 1. Ischemic stroke, blocked artery, brain damage. It's permanent, which makes it different from a TIA. The blockages are usually from plaque or a clot that started in the heart, and the symptoms you see are a direct map to where the problem is in the brain. Got it? Good.
All right, so now we know what a stroke is. Let's step inside the emergency department, where the diagnosis has to happen at lightning speed. The patient has just arrived, and that clock, it is ticking louder than ever. This is a true race against time.
Before a single test is run, before anything else happens, the medical team asks one question that is more important than all the others. When was the patient last known to be well? That answer, right there, starts the official stopwatch. It determines if someone is even eligible for the most powerful, time-sensitive treatments. Literally every decision from this point forward hinges on that piece of information.
Okay, next up, we have to figure out how bad this is. To do that, clinicians use this standardized tool, the NIH Stroke Scale, or NIHSS. Think of it like a scorecard for the stroke. It's a 42-point scale that objectively measures all the key neurological functions. The higher the score, the more severe the stroke, and that score helps guide just how aggressive the treatment needs to be.
Now, this is where it gets really interesting. The very first imaging step is to rush the patient to get a non-contrast CT scan. And you might think the goal is to see the stroke, right? But actually, no. The number one priority is to rule out a brain bleed. Why? Because the main treatment for a blockage is a clot-busting drug, and giving that to someone who's already bleeding in their brain would be absolutely catastrophic.
So while the patient is literally on the way to the CT scanner, someone is drawing blood for essential labs. We've got to check their blood sugar because super low sugar can actually look just like a stroke. We check clotting factors, platelets, but here is the most critical part. If you don't have a reason to suspect a problem, you do not wait for these lab results to come back before you start treatment. Remember, time is brain. You go.
So, to recap that diagnostic sprint, you establish the last known well time to get the clock started. You use the NIHSS score to figure out how severe it is. You get a CT scan right away, mainly to rule out a bleed, and you run your labs at the same time without letting them delay any of these other critical steps.
So, the diagnosis is confirmed, we know there's no bleeding, now we enter the treatment phase. And here, there is one single, all-important goal: reperfusion. That's the fancy word for getting blood flowing back to that starving brain tissue as fast as we possibly can.
Before we even get to the really big interventions, there's some foundational care that has to happen. Patients are admitted to a dedicated stroke unit. Just being in one of these has been shown to reduce mortality. Then, it's all about the ABCs: airway, breathing, circulation, and tightly controlling their temperature, their blood sugar, and especially their blood pressure. And this slide illustrates a really key and kind of counterintuitive concept in stroke care. Blood pressure management is this delicate balancing act. See, if a patient is a candidate for those clot-busting drugs, we have to lower their BP to below 185/110. That's to reduce the risk of bleeding. But if they are not a candidate, we actually let their blood pressure run high. It's called permissive hypertension, to try and force blood past that blockage. Two totally different strategies.
Okay, so the first major intervention is IV thrombolysis. This is the clot buster drug we've been talking about. It's an incredibly powerful medication that can dissolve the clot, but it has a very strict time window. You have to give it within 4.5 hours of when the patient was last known to be well. And, as we said, it's an absolute no-go if there's any sign of bleeding.
But what if the clot is just too big and it's blocking one of the brain's major arteries? Well, drugs might not be enough. And that's where endovascular therapy, or EVT, comes in. I want you to think of this like a plumber's snake for the brain. A specialist threads a tiny catheter all the way up to the clot and then physically pulls it out. And what's amazing about this is that the time window for EVT is much, much wider. It can be done up to 24 hours out in the right patients.
Okay, let's just quickly recap those key treatments. First, remember that blood pressure goals are totally tailored to the treatment plan. Second, IV thrombolysis is the clot-busting drug with that tight 4.5-hour window. And third, EVT is the clot retrieval procedure for bigger blockages, and that can be done up to 24 hours later. They're different, but they both have the exact same goal: restore blood flow and save the brain.
So, the clot has been busted or it's been pulled out. The immediate, life-threatening danger has been dealt with. But the journey is definitely not over. Now, the focus has to shift to managing the aftermath and doing everything possible to prevent this from happening again. The risk of having a second stroke is actually highest right after the first one. So pretty quickly, within 24 to 48 hours, patients are started on antiplatelet meds like aspirin. These make the platelets less sticky. Now, if the stroke was caused by a clot that came from the heart, they'll be started on a stronger blood thinner called an anticoagulant.
In the first few days after a stroke, the brain is incredibly vulnerable. The entire medical team has to watch like a hawk for serious complications. Things like brain swelling, or cerebral edema, or bleeding into the already damaged area, or even pneumonia that can happen if the stroke affected their ability to swallow safely. Seizures are also a risk.
And as soon as the patient is medically stable, rehabilitation begins. This is a huge team effort. You've got physical therapists, occupational therapists, speech therapists, all working together. The goal here is to help the brain literally rewire itself and to help the patient get back as much function and independence as possible. It's pretty interesting, though, that we actually avoid really intense therapy in the first 24 hours just to give the brain a little time to start healing.
So after all of that, it all comes back to this one central, powerful idea. Time is brain. From the very first symptom to the final treatment, the entire system of stroke care is designed to move as fast as humanly possible. And that leaves us with the big question for the future. With incredible new technologies like mobile stroke units and telemedicine, how can we shrink that timeline even further? How can we shave off more of those precious minutes and save even more brain?